Strong.
Did you see that
I did. I took 4. Yeah, we're strong men, so it was rough. Apparently, the guy who was wrecking also wrecked world's strongest match. This event was heavier than world's strongest.
oh, gosh, that'd be so fun.
My back, I actually flew in today. Like I got back 3 hours. And my back is telling me to F off.
So, all right, guys, welcome to class. I only had 8 people fill out the survey in the announcement about whether you want me to go over the exams after class, after the exam on Thursday. Who filled it out?
I did not.
So what I understood from a long time ago from talking with them is that I can show you the questions and we can go through them, but you can't record anything, you can't write anything down, you can't take anything from the room because they're protected exams. But I think it's really unhelpful for you not to know what you missed, right?
Yes.
So we can do that after we'll do exam 3, and I'll try and go through and do a quick assessment of the grading, and then we can just start with exam 1 and go through it, exam 2 and exam 3, and that'll delay us starting new material, but I don't know. I think it's probably helpful to know now what you missed so you can go back and reread and study. So far I have 7 people and 6 said yes and 1 said no. So
I just said yes. Yeah.
okay. So I will just plan on doing that, and I think it's smart. Thank you to the people who mentioned that that would be helpful. After we go through fluids and electrolytes today, I made an exam review. It's just questions and answers. We don't have any caboodle, cost money, and it'll take the college a long time to get their ducks in a row and sign up for that. So whoever was doing it is paying out of their pocket. I'm not doing that. I already paid enough things out of pocket. So it'll just be regular, and it really does include in one way or another the information that's on the exam. So it's good to always come and participate.
Oh yeah. And we'll have access to that after the class.
Yeah.
Great, thank you.
Yeah. Not after class.
Oh, I'm good with that too.
Yes, and I'm still offering. I'm happy to tutor anybody who's having issues. If you're borderline passing, I think now is a good time to.
So are you offering a Zoom session?
I'm offering, I guess, whatever would be most helpful, whether it's a Zoom session or stay, come before this class or stay after on Thursday, and just to go through whatever people are missing. I figure with the with the exam review, of course, you don't know what you missed, but you will know. Hopefully you'll recognize the questions when we go through the exam review, and hopefully you'll remember what you put. It's just really inefficient, and I think in future, for those of you who want to visit me again next term, which I don't want any of you to do, please take me up on an offer. I'm happy to help you pass. So there's really only a couple of questions on the exam about solutions that I can recall. And so just knowing the basic differences between crystalloids and colloids, I always remember crystalloids like crystal light, it's electrolytes. So it doesn't have any plasma proteins, it's just made up of various electrolytes, whether it's normal saline or what. They are usually maintenance fluids, dehydration, if we have some renal issues and we're trying to get flow, lots of reasons that we might use it. It does have a lot of adverse effects. It's fairly innocuous. You're not going to have drug interactions necessarily, but you can get fluid overload from second spacing, as they call it, and dilution of your plasma proteins. And so, and then when you put fluid in, generally people pee it out, so it's temporary, right? So colloids contain plasma proteins, either albumin, dextrose, or hexastarch are the three that are out there. And that's to move things from outside the vascular system back in. So whenever we've had fluid leak somewhere and we want to pull it back into the bloodstream so that it can be filtered and excreted, we need more plasma proteins to pull it in. You guys remember about, like, so these are your plasma proteins, and they have a really strong magnetic effect for water. And this is a semi-permeable membrane, so the plasma proteins can't get out. And so in order to equalize, because you have other stuff out here, in order to equalize this, you have water going in through here, it's drawn in through all of this semi-permeable membrane, and it gets drawn by this sort of the attraction between water and your electrolytes. Let's see. The problem with both colloids and crystalloids is, of course, it doesn't have any oxygen carrying capacity, right? That's only for blood products. Let me move this thing down because I really don't want to see that. How do I hide that? That. All right. So we use that for a few reasons, and there are some choices that we make depending on the clinical scenario. We try and avoid it if we can because it's the most expensive and the most scarce of our resources. There's always a demand for blood, and we don't have enough to keep things moving. So these are the main ones that we talk about. So fresh frozen plasma contains all of the coagulation factors. So if somebody had a volume loss maybe, and it was due to a bleed from lack of coagulation factors, you may either give whole blood, but more likely coagulation factors. And then we packed red blood cells, that's, everybody knows that's spun down, that's the red blood cells that are spun down, and we take all of the, we take everything else out. We generally use it for people who have had a blood loss, 25%, yeah, 25% of their total blood volume acutely, like trauma, that somebody was in an accident and they bled out. This is in cases of extreme blood loss. We want to just get whole blood because it also has plasma and clotting factors and everything. So if somebody's lost greater than 25% of their blood volume, we're just slamming them with whole blood. Same risks for volume overload and all that kind of stuff. But yeah, most people know that blood products have to be typed and matched or crossed and matched because we're trying to get it as close as we can to some specific markers within the recipient's immune system. So the risks of transfusion that you will get to explain to patients when you consent them, as they say, did you consent them for blood? You will be going through all of the risks of a transfusion reaction and anaphylaxis, that even though the products are screened for infectious disease, there's still a risk. And then you should always know that we only use NS with blood products. That's the concentration of the plasma is 0.9% sodium, so we want it to be isotonic. What do I want to know about electrolyte balances? Probably we're talking about potassium here. Yep. So potassium is the most abundant electrolyte inside cells. So we have all of our cells here, and there's potassium in them. Then we have our bloodstream, and we usually have sodium here. Well, what happens if we, for some reason, we damaged a whole bunch of red blood cells, or cells, not blood, red blood cells? This potassium is released and reabsorbed into the bloodstream. So anytime cells are damaged, you're going to have hyperkalemia when you check their chemistry panel, and it's because of the destruction of cells and the release of potassium. So one thing that you may end up doing in order to fix this is to administer insulin. You may also be giving them D5W in order not to make them hypoglycemic. And the role of insulin has nothing to do with blood sugar per se. Insulin drives potassium back into the cells. So it's one way we can lower our serum potassium is using insulin. So that's for elevated serum potassium. Obviously, if somebody's low for whatever reason, whether it's drug induced or they have an underlying adrenal disorder or whatever it is, you guys know the therapeutic range, what it's responsible for, and then all of the precautions that go with it, like it's a slow infusion, it is a caustic substance, so you can get a phlebitis around the IV site. What else? We do prefer to give it oral if we can. So the problem with oral preparations is that potassium is kind of hard on the stomach. I like to think of it as caustic, something that's really erosive. And so there are certain people who shouldn't have potassium, somebody who has an active GI bleed or an ulcer, someone who has taking other medications that delay gastric emptying, then the potassium would stay in here too long. So one of the things that you'll see with, you may get asked by patients is they'll say, I don't think I'm getting any of that potassium because I see it in my stool. Anybody ever either experienced that or had a patient tell you that, like they saw it in their stool? Well, potassium is actually put in a waxy capsule, the waxy outer coating, in order not to dissolve in the stomach because it's very erosive. And so what they're actually seeing is the outer capsule, but the inner portion of it has been dissolved and absorbed. So you can always tell them, you know, hey, that's just the outer coating, and you know, you got your medicine. We can tell because your lab tests improved. All right, so rate of administration, yeah, pain at the injection site. These are all of the issues with oral potassium because of its tendency to irritate the GI tract. This is when, oh, this must be like a solution or a powder, because it does come in a solution for people who can't swallow pills. And then, yeah, we always are monitoring for the adverse GI effects. So these are the things they want you to know about administering IV potassium, that you can't give it faster than 10 milliequivalents an hour if they're not hooked up to a cardiac monitor, because you risk arrhythmias. And so they give you the rate. It's never an IV bolus. It's never undiluted. It's always a bag, you know, a full liter solution. It's a lot of fluid, unless they're, well, it might be less if they have bad heart failure and they're in fluid overload, but usually it's in a whole liter. So the risk of doing this is you get too much potassium, right? So you get the exact opposite of what you want. So there's lots of ways we can treat it. So as we said, insulin, and then by giving some D5W so that the insulin doesn't lower the blood sugar too much. These are other ways, IV sodium bicarb. There is a K-exolate. These are used more in a dialysis type patient, but you might see it in the hospital if somebody's super hyperkalemic and they think they can reduce it. K-exolate is the antidote for oral potassium. So then we have sodium. We know about hyper and hyponatremia and how it can be because they may have dilutional hyponatremia where drinking a whole lot of fluids, or they have a lot of sodium loss, electrolyte losses. No, losses would cause them electrolyte losses, yeah. So we watch for the symptoms. 135 to 145 is where we want them to be. These are all the signs and symptoms that they ask you to watch for. So if they give you a patient scenario that happens to include some symptoms and some lab values, and one of them is sodium, put it all together that perhaps they're hyponatremic. This is sodium. So here's our BJ. Wow, a 62-year-old patient with a history of alcoholism. Presently, he has 3+ pitting edema from mid-calf to his toes bilaterally. Fluid seeps from his ankles. BJ has a protuberant abdomen that's filled with acidic fluid. His LFT results were markedly elevated, and his albumin is 2.0. Provider orders 5% albumin daily. The nurse is reviewing the appropriate measures for administering the albumin. What are 2 considerations the nurse will keep in mind regarding the administration of albumin? So first, albumin is what?
Protein.
Is it a crystalloid or a colloid?
Colloid.
Okay, it's a colloid. If it's in a solution.
What is usually so that albumin is 2.0 grams? What is usually the? I don't know the normal.
Well, then you'll look it up and know it before the
Okay.
exam, right? The nurse will keep in mind that albumin is contraindicated in patients who are allergic to it. We don't give people albumin for heart failure, severe anemia, renal insufficiency. It's also administered slow and cautiously. And these are more about the volume of fluid that's being infused, this renal insufficiency and heart failure. And then if you're putting a lot of fluid in, even with plasma proteins, you're diluting your red blood cells even more. And increasing the volume that the heart has to pump around. So you would actually be increasing the workload of the heart if you were adding a colloid fluid, simply by increasing the volume and not giving any more red blood cells. Kind of sad. What concurrent condition, if present in the patient, would cause the nurse to question the order for albumin? So what might he have that would make you say, I wonder if I should really give this albumin? The heart failure was one of them, renal disease, severe anemia. How about, heart failure. Albumin, other colloids cause, it's just what we said. What patient outcome would indicate to the nurse that the albumin infusions have been successful? Right, shift of fluid back into where you want it to be. So decreasing his edema, he had ascites, that term acidic, it's not acid, it was referring to ascites, secondary fluid from lots of places, could be liver, could be pulmonary, and gravity pulled it down. So we'll raise the blood pressure because we increase the volume while maintaining the level of colloids or plasma proteins, so they're not diluted. If you didn't do that and you put a bunch of fluid in, so imagine someone needed a fluid and you didn't give albumin, you gave NS. What would happen to their fluid status? So what would happen to their presentation? What would you see?
They get more bloating.
And what's the mechanism for that? So we're lacking the colloids in here, right? And so if we don't have that oncotic pressure to keep the fluid in here, it just slowly drifts out into the interstitial spaces, and gravity pulls it to the lowest place. So that's the reason we're careful in these patients. So crystalloids, colloids, potassium, basically
That was it.
yeah, that's not bad. Let's do anemia. Now we're going to keep anemia super simple, even though I would love to go on and on about anemia. I think it's the coolest thing ever, not to have, but to figure out.
To treat somebody else.
It's really complicated. It can be. So the production of red blood cells is called erythropoiesis, and that's applicable when you start talking about the medications to induce production of red blood cells, erythropoietin. So you can see where it got its name from. That's the process. So our red blood cells, our blood cells in general, are manufactured in our bone marrow. They last 90 to 120 days. Depending on the person. We need heme, and we need globin. Makes sense. Globin is a protein. Heme is the part that contains the iron. So if you're missing one of these components, right, you can't make hemoglobin. If you can't make hemoglobin, then you are not able to carry your oxygen around to all of the cells of your body. Yeah, oxygen. We consider red blood cells to be like, so I had this guy, he had a condition that he didn't understand because he was a little bit cuckoo and he was an older fellow. And he just couldn't grasp it. So he just kept thinking if he wore oxygen and put more oxygen and dialed up the concentrator, that would solve the problem. Right, but if all of your red blood cells are already saturated with oxygen, doesn't matter how much you crank it up, you're not going to be able to carry anymore. So we consider our red blood cells to be, he was a former construction worker, worked in mining. Your red blood cells are your dump trucks, and your oxygen is what you carry in your dump truck. You may have a large load you need to carry, but if you only have 2 dump trucks, you can't, it doesn't matter how much load you have to carry. So then he was like, oh, okay. So you turning up my oxygen.
Get more dump trucks, right?
So where could I get some of them dump trucks? And I told him, and he said no, because he was Jehovah's Witness and they don't take.
Oh no.
It was a bad one. So most of our anemias, they're not ones that we're born with. You know, we're not usually a hemophiliac, or we're not born with sickle cell disease. I mean, most of them, it comes from either kidney disease and aging, and we get kind of poorly formed red blood cells, or things that are destroying them, whether it's a medicine that is destructive to red blood cells. A mechanical heart valve is destructive to red blood cells. It actually will crush them as the heart valve. Just a mechanical one, not like a prosthetic valve, a Kate porcine or anything like that. The old-fashioned ones you can hear across the room, that click, click. Yeah. I can hear your heart rate from over here. They're awesome. And they slam shut on the red blood cells and crush them. So we just watched. You should know all of the signs and symptoms of anemia. You know, mostly we're going to be talking about fatigue and lack of energy, dizziness. We feel weak. Any exertion, I feel short of breath, and my heart is pounding. Now that can sound like a whole bunch of other conditions as well. But if we know that this person's only issue is that they're anemic, it's nice to be able to explain to them why he has these and why whatever he's doing for his treatment, depending on what the cause, why that would help. So what we say were the 2 essential things for normal red blood cell production. Heme, iron, well, heme that contains iron, and globin, which is a protein. What are two main causes of iron deficiency anemia? So iron deficiency anemia. And let's not say we don't eat enough iron. Let's not say it, because we're in a first world country and we have access to nutritious food. Why are women more prone to iron deficiency anemia? Menses, right? So the whole cycle of red blood cell production, when the cell dies, the heme is recycled. We have a wonderful system to just keep recycling it, but there's no way to recycle blood you've lost. You can't get it out of the garbage or the dump, recycle it. What's another reason you might think we have iron deficiency anemia? Childbirth, acute blood loss, that could be one. You could have a slow bleed, like a GI bleed. Sometimes you can just lose 5 drops of blood a day and never see it in your stool and become pretty severely iron deficient anemic because you've lost whole blood and you can't recycle that heme anymore. What happens to red blood cell production if a person has kidney disease? So you have to know why kidneys are involved in blood cell production. Right, erythropoietin is produced in the kidneys. Erythropoietin is what acts on the bones to stimulate them to produce red
kidney failure.
Right, if you have advanced kidney disease, kidney failure, it doesn't affect just filtering of urine. It affects all of the functions of the kidneys, which include stimulating the bone marrow to produce red blood cells. So people who have kidney disease, they often don't understand why they're anemic. I eat good. This has nothing to do with you eating. Usually when they're at dialysis, they'll get IV iron infusions and possibly erythropoietin, the actual stimulant. So this is the agent, apotin alpha, known by the brand name Epogen. So yeah, it's the hormone it's the replacement for the hormone. And we use it for like advanced kidney disease, chemotherapy induced, anything that's, there might be a myelodysplastic disorder. There's a few things, but it has to be pretty anemic. There's a threshold for blood receiving, starting on this. There's a threshold. First, they're going to try and give you packed red blood cells and see if you're able to hold on to them, and investigate why you're losing red blood cells. If it's related to a process that is not reversible, like end-stage kidney disease, then there are numbers they watch for your hemoglobin, when they will administer it and when they will stop, right? There is a longer acting form called darbepoetin. So there's erythropoietin, epotin, and then darbepoetin. And we like this one just because it has a longer, once we know how they respond to a shot, because every person will respond differently. We're watching how much their hemoglobin rises. And some people will get a giant jump and some people will just get fairly a little one. So we like to know how much they jump, and then we may switch them to this Darby. So for people who are not on dialysis, who have chronic kidney disease, we want to keep their hemoglobin above 10. So what's a normal? Obviously, men and women, we've decided that we don't have the same hemoglobin levels to be considered normal. Where does a man fall versus where does a woman fall for normal? Man is around 15 and depends on your lab. Every lab is going to have a little different number that they're following. 12.5 to 13 is what we consider more normal for a female. So this is the maximum we want them to be. So their hemoglobin may have been 6. That's super anemic. That person is exhausted. They can hardly do anything without being out of breath. So we want to get them up to a 10, and then we'll stop doing it. Someone who's on dialysis, we try and shoot for 11 in order to reduce the need for blood transfusions. Why do we want to reduce blood transfusions? In what way? Okay, yeah, transfusion reactions. And what we know is the more you are exposed to blood products that are not your own, you have a compounded risk of having an anaphylactic reaction, because you're not getting the same person's blood every time. You're getting different people who have a lot of similarities, but they also have a lot of differences. And so the more blood transfusions you have, the more likely you are to have a reaction. So we want to minimize that. And it's also expensive, right? And it's our most valuable resource, human blood. We don't have a replacement product for it, even though we're trying. So knowing the signs and symptoms of a reaction, and then going higher than our goal increase the risks of having a blood clot. Why do you think that is?
Why do you think it's another agent, and when you're putting the body something, not
No, because it's a biosynthetic. So your body recognizes, I guess you could have a reaction to the inert components of the medicine, but it's not related to the medicine. Yes.
I was gonna say increasing.
Increased red blood cells increases the viscosity of your blood. Now you have more concentrated red blood cells that are more likely to want to all jump together and make a clot. So that's why we have such a low cutoff where we stop the medication, because nobody wants to have a stroke or a heart attack or a PE or a DVT. Before you administer Epotin alpha to a patient with renal failures, it's most important for the nurse to assess which laboratory result. Yeah, of course. We're going to look and make sure that they're meeting the criteria. Maybe they self-corrected, or maybe they went to an outside hospital and had a transfusion that they forgot to mention to you or something. There's lots of times where you need to just double check that. There were some options here about like, let's see what was looking. There is the risk right after you are giving this that you can have, right after, meaning the first hours to days, that you can have a sudden rise in blood pressure while the hematocrit is increasing. So of course, like any medicine, you're going to have a strong rise in the beginning, and then it kind of peters off. But this strong slope of rise of red blood cells is when you're at risk for having hypertension, because now you have red blood cells that are acting like a colloid and pulling fluid into the vasculature. And so we're having increased volume in the vasculature. It all settles down, but they're at risk. And then we talked about the risk for clots. Iron, so there's Iron Man. So iron is the oxygen carrier in hemoglobin and myoglobin. We know where it's stored: liver, spleen, and bone marrow. Some people don't have a spleen. If you have liver disease, then you're going to have issues with iron, right? If you've got a cirrhotic liver, you're going to have issues with the functions of the liver. Just being aware that not all anemias are from iron deficiency. So being very sure what the cause is sort of critical. If somebody has an anemia and it's because they're missing vitamin B12, well, that's not an iron deficiency anemia. That's a different anemia, and taking iron is not going to correct it. Let's see, which food will the nurse encourage the patient to take with an iron supplement? Right, that's an easy one. We know that vitamin C facilitates absorption of iron. And some people, I've had diabetic patients who we don't really want them drinking a glass of orange juice because they don't drink a juice glass, and then they drink it. So sometimes we'll prescribe ascorbic acid, which is vitamin C. They'll just take them at the same time. But there are lots of other things that you can recommend that are high in vitamin C. All of the citrus fruits. Don't tell them to eat grapefruit, right? Now we all know we just generally avoid grapefruit. But lemons and limes and all of our dark leafy greens, some of our fruits are high in vitamin C. So they don't want to, you know, have strawberries with your morning iron. So there are lots of dietary iron sources. Obvious one is from meat because we're getting their heme from their red blood cells. We're just ingesting them and recycling them in our cells. I like to go over, there's a misconception that a vegan diet is missing iron. Vegans are no more likely to develop iron deficiency anemia than the general population because generally people who eat a vegan or plant-based diet are eat a well-balanced diet and incorporate a lot of methods to increase iron intake. So just cooking in a cast iron skillet, the iron leaches into your food. So you get iron by just cooking in a cast iron skillet. They actually sell a little iron fish. It's a fish made out of iron. It's about that big. And people drop it in their food that they're cooking because not everything can be cooked in a cast iron skillet. And it will leach iron to what they're cooking. So there's that. Then just the products that we choose, all of the soy products and other legumes. And we can have iron in our vegetables, nuts and seeds and fruits. There's iron in lots of things. So I'm no more likely to tell a vegan to take an iron tablet than I am to tell the regular population. However, there are some foods that impair iron absorption. And we typically tell them don't take it with milk, or don't have yogurt at the same time. Calcium interferes with the absorption of iron. And so does, and interestingly enough, eggs does as well. And eggs is a source of iron. It's the weirdest thing. Don't ask me how it works, but generally what we do is you do the teaching, take it with some citrus fruit or fruit juice or strawberries. Don't take it with milk. And then we talk about, let's see, why do we give iron? Prevention and treatment of iron. We're trying to get rid of the symptoms, but we have to address the underlying cause. So if somebody has iron deficiency anemia, and it's a man, and he's 42 years old, generally speaking, we want to figure out why. In that population, we're looking for risk factors. Is he a smoker? Is he a day worker who carries heavy loads and would be bearing down and having hemorrhoids that might bleed? So we worry about a malignancy, a cancer. A cancer can cause anemia. So we're always trying to go to the root cause of why does this person have anemia, not just give them iron, because that's treating the symptom, not the cause. What is the #1 cause of iron deficiency anemia in first world countries? That's a good question. I don't remember what the answer was.
Hemorrhoids.
I'm trying to remember if it was menses or poor diet. I don't remember. So there's lots of iron replacements. They come in all sorts of tablets, and they're not all equivalent. Fumarate, gluconate, sulfate. There's more than that. Generally, I don't memorize. I just look it up when I'm prescribing to know what's the elemental iron that's contained within it. So even though it may say 324 milligrams, it may only have 81 milligrams of elemental iron, and that's the thing we're looking at. But just recognize there's oral tablets, and there are some precautions with them. And then we have this parenteral or IV, and there are some issues giving iron dextran versus iron sucrose. Let's see if I went over them. So here's the thing. The recommendation is to take iron on an empty stomach. Has anyone ever tried to take iron on an empty stomach? What did you feel?
It hurts, it makes you vomit.
It hurts your stomach. It's awful. It's awful. It causes terrible stomach pain. Not everyone, but I'd say the vast majority. So we recommend that they get the maximum absorption on an empty stomach, but obviously if it upsets their stomach, take it with a meal. I'd rather have them have it with a meal than skip taking it, right? Should be given with citric acid juice, not with milk or antacids. That's because lots of antacids contain calcium. There is this sort of recommendation on the liquid preparations. They're kind of staining, and so they recommend, just like with other products that are either bad flavored or staining, that you drink it with a straw so that you can bypass your teeth and swallow it so you don't end up with iron stained teeth. And that's a patient teaching item. You just are checking what formulation they're getting. If it's a kid, that might be applicable because not every kid is going to do it with a dropper. And then here's another one. People who take oral iron and even IV iron are supposed to remain upright for 15 to 30 minutes, but in specific oral iron, and that's because iron, again, if it hurts your stomach, you know that it's a harsh substance to your gut. And so if you lay back and your esophagus is now parallel with your stomach, you risk this iron sort of backflowing to the bottom of your esophagus and causing ulcers and erosions and things like that. So staying upright. So those are the key points to know about giving iron. This is the most common cause of pediatric poisoning death, is kids taking iron. And now iron comes in gummies. I know, they're delicious and kids will just eat the whole jar. The poison control, they tell us that it's iron that parents call the most about. These are the side effects and they're all related to the GI effects of iron. It's interesting that it can cause constipation or diarrhea. Typically it's constipation. However, there was a patient I didn't believe for a really long time. Kept saying, no, it causes constipation. He argued, no, it gives me diarrhea. It really did give me to look it up. And I'm like, oh, yeah, I guess it could. So more likely constipation, nausea, pain, and then educating them that sometimes generally speaking, it'll cause a black tarry stool, kind of a sticky one, which can be mistaken for a GI bleed. So lots of calls to the doctor's office after somebody starts on iron. I think I have a bleed because they told me I have a bleed if I have a black tarry stool. And yeah, so oftentimes it's just the iron. Now this is the ones that you have to be careful of. Iron dextran is known to cause anaphylactic reactions as well as significant orthostatic hypotension. So anyone who gets iron dextran has to have a test dose first and then wait for an hour, and then the remainder of the dose is given. We don't give it as frequently because of this, although we still do give it. Typically, we're going to give iron sucrose because it doesn't require that test dose. So this is something you should be aware of. The nurse has administered iron intravenously to a patient. To prevent orthostatic hypotension, it's recommended that the nurse have the patient remain in the recumbent position for how long? 30 minutes? What's a recumbent position? Recumbent would be, 30 minutes after an IV infusion of iron to prevent drug-induced orthostatic hypotension. So that's another thing you should know. All right, so folic acid is another component for making red blood cells. It's another ingredient in the cookie recipe. So we've got to have folic acid. The main time we worry about deficiencies is during pregnancy, right? Every woman who's had a pregnancy and was followed by medical care knows that they were immediately put on iron deficient folic acid to prevent neural tube defects. The recommendation is that you start taking it a month before you intend to get pregnant
because oftentimes the neural tube is what's developing early on before you even know you're pregnant. And the last thing you need to have is a really awful birth defect that could be fatal. Usually, it's a malabsorption. So for some reason, we're eating it in the foods that we consume, but we're not absorbing it. And then alcohol can cause it. That's twofold. One is that people who drink a lot of alcohol typically don't eat a lot, so they're replacing the healthy food with alcohol. But also it changes our GI tract, so we can't absorb well. And then some seizure medications interfere with B12 absorption. So it leads to what they call a megaloblastic anemia, and it just means mega means big, and the blasts are the cells. And when you look at it under a microscope, it's extra large. It's larger than the normal one. And yeah, we don't tell people to take extra folic acid unless we know that's the reason they're anemic, or unless they're, been instructed to take it because of pregnancy. It can mask some symptoms of pernicious anemia. So there's basically iron deficiency that we'll talk about, folic acid deficiency, and then pernicious anemia. Go back to folic acid food sources, lots and lots of food sources for folic acid. Typically spinach has the highest of all the foods. So, but if somebody is avoiding eating large amounts of leafy greens because they're on warfarin, then we want to offer them other options for folic acid. We'd always rather people get it in their food rather than a pill. Oh, I already told you, to prevent fetal neural tube defects, when should folic acid be started? I could have swore I just said that, at least a month before pregnancy, and then just through early pregnancy when the neural tube is developing. All right, pernicious anemia. So pernicious anemia is a lack of vitamin B12. And it's not necessarily because of a lack of B12, it's a lack of the protein called intrinsic factor. And intrinsic factor is released by cells in the stomach. So if you have issues with your stomach, whether it's you have a lot of inflammation in there because you take a lot of NSAIDs, or you eat have a lot of gastric acid,
Drinking a lot of alcohol.
drinking a lot of alcohol, yeah. Or if you've had surgery, if you've had a gastric bypass, if you've had a sleeve gastrectomy, you lack the surface area of the stomach in that case to produce intrinsic factor. Usually it's an autoimmune condition that happens. So our own body is attacking the cells in our gastric mucosa and destroying the cells that produce intrinsic factor. So yeah, anyone who has gastric or small intestinal conditions or surgeries probably will develop pernicious anemia. So anyone who's undergoing bariatric surgery, I mean, we already know they're going to be put on a B12 supplement.
That's also good. B12 shots every few months.
Yeah. Yeah, and if you, so we don't give intrinsic factor to replace it so that we can absorb. We give B12. It seems funny that.
See, the same you say about the truck.
Yeah, we don't give the intrinsic factor for whatever reason. We haven't produced a chemical that's stable enough to do the job. So we just give B12, probably because B12 is so cheap. So if we give it parenterally, then we've already bypassed the absorption, right? If we give it by injection, then we don't need the intrinsic factor to absorb it. If you still have some working intrinsic factor, we may give an oral B12 daily at a little bit higher of a dose, well, much higher than you'll find in a multivitamin, like 1,000 micrograms, which is what's in a typical B12 tablet. Take a high dose every day. If you still have functioning stomach cells that are producing intrinsic factor, then you can absorb it. But some people just prefer to have an injection, however often it works for them. So this is what are we looking at? B12 deficiency anemia looks a little bit different than iron deficiency anemia, even though it's an anemia. And so some of the unusual symptoms are this peripheral neuropathy, sort of the paresthesias or tingling sensation, or an actual burning or numbness of your extremities. And it can be due, so anyone who has that symptom and they're coming into the hospital or whatever, one of the labs besides checking for diabetes is they check for B12 deficiency, because it can lead to these symptoms. So just kind of being aware that we do want to treat it, because if we don't, you can get irreversible neurologic damage. It's not a small thing just to be B12 deficient. B12, yeah, you just said that. All right, that's all I got to say about anemia and fluids and electrolytes. Isn't that awesome?
We're done for the exemplary.
Now we can, yeah, you can take a break. Now we can review. You've got all the information, you now will ace it.
Here, I can try another way. There you go.
I saw Megan. I saw you come in. The next.
And then put it in, and then it's
I remember this 3:30.
August 12th.
Was Kelsey or Kaylee here?
So,
I don't think I saw her.
There was
Or Alex.
my husband forgot my birthday. It was funny. You know the amazing world of Kafka? Sounds really familiar. So he's like, they were like in and she, I think she looked at him, he's like, and he's like, I forgot your birthday. And he went out into the birthday tattoo.
And Cleo was like, Daddy,
no, they had to be
He's just looking at me.
so I was a little ticked.
And then I said, I feel like screwed up.
She could have went about it.
But then
Yeah.
is why you figure.
Here, what is it? Tell me.
It's not my problem.
It's not.
No.
All right, are we ready to dig all the way back to hypertension? You can remember that far back to last week. Yeah.
I've been studying that. I don't know.
Yeah. Just break it down by class. It's just the way you do it. I don't the same thing as you did with cholinergics and adrenergics. Break it down. Everybody here has clinicals, right? No, not everybody does clinicals this term.
Not everyone in this.
Not everyone in this class.
Only a few foundations
Okay.
or med-surg.
Just helpful to, if you have clinicals, to be looking at the meds and seeing what you recognize. Kind of helps you put it into your brain in a little more solid way when you connect it with a patient and a condition, somebody you saw. All right, well, we can either just do it as a nice class or we can have a competition.
It's a nice class.
She was looking at me like, yeah, competition. Oh, let's just go through. What should the nurse tell the patient to do or not do after they take their oral iron? Lay down. It's not lay down. Okay, let's see. Remain upright.
And they need to eat.
Okay. No, eating is not a
Oh, so
instruction. Oh,
So
after,
don't drink milk.
So don't lay
no,
down
this
for
is
30
after they
minutes.
take it. It's not while they're taking it, it's after. So you're right. Stay upright. The nurse is preparing an infusion for a patient who has a deficiency in clotting factors. What type of infusion is most appropriate? Right, everybody know what FFP is?
No.
Fresh frozen plasma contains clotting factors. Right, so whole blood will contain it or fresh frozen plasma, but if we can take whole blood and divide it up into the components and use it on multiple patients, it's better.
Do we gonna have this, you gonna leave it for us to?
You're gonna have fresh frozen
No,
plasma?
no. The power test, yeah. Thank you.
When giving antihypertensive drugs, the nurse will consider giving the first dose at bedtime for what specific drug class? Yes, there are many, but we noted one class has a specific precaution.
Beta block. Beta block. No.
No, they all have the tendency to cause orthostatic hypotension, but there was a specific class of drug that we said, we actually probably covered it when we were doing anticholinergic drugs. So they are alpha blockers. Like doxazocin, terazosin, alfuzosin. And what are they also used for? What is this category of drugs besides blood pressure? Typically, what are they used for?
It is for hypertension, right?
It is for, it can be
Low
used,
blood
it's not a
pressure.
first line for hypertension by any means. But it can be used. But the primary use of these drugs is something else. What do we use? Doxazocin, terazosin, alfuzosin, BPH, benign prostatic hypertrophy. Yeah, click, right? All right, pull out your brain. The order reads, give hydralazine 0.75 milligrams per kilogram per day. The child weighs 16 pounds. How much will be given in a day? And then round to the nearest 100. You're just doing this in your head, John. He's like calling out numbers. Let's see, 16 pounds, convert it to kilos.
100, sorry.
I got it.
545?
Check my math.
Nearest 540.
It is
And then, so now you know how many kilograms it is, so you multiply it by,
5.45.
that's how many kilograms, so
Oh,
then you
that's
multiply it by the dose
Yeah,
per
that's.
kilogram, right?
Yeah.
So what's the answer?
5.45.
No, that's
Yeah.
That's
5.45.
yeah.
5.45. See, I was right.
Did you do that in your head? Rain Man?
Not this time.
I don't think they know really.
I was close. I was close.
They need to watch it.
They do.
Tom Jones, 213.
They definitely know my underwear.
Okay. A patient in the neurologic ICU is being treated for cerebral edema. What class of diuretic is used to reduce intracranial pressure? Osmotic diuretic, right? Anything that's going to pull fluid into the vasculature to reduce pressure. All erythropoietin drugs carry a black box warning about what potential adverse effects.
Blood clot?
Yeah.
Yes.
Heart attack, stroke, death, consequence of increased viscosity, and we talked about the numbers for people. Name 3 common adverse effects associated with nitroglycerin.
Hypertension.
Headache, hypotension,
No, diffusion.
Hot flushing.
Erectile diffusion.
we have flushing.
Yeah.
Yeah, so what other drug gives flushing?
Niacin.
Right? So don't get confused that thinking, oh, that was niacin. So nitroglycerin, and it's all related to vasodilation, right? That's why you flush, is because you're vasodilated. So getting a headache, having hypotension, passing out, it's all related to the mechanism of action. Patient has a new prescription for an angiotensin receptor blocker, antihypertensive. During a med review, ignore the word that, the nurse would be concerned about an interaction with this new prescription and what other drug? An ACE is one. What else? Because you know, yeah, we got that. Never take an ACE and an ARB together. What else? What's the risk on an angiotensin receptor blocker? What are some of the lab values you're watching? So what wouldn't you want to take it with? Yeah, with oral potassium, right? So we've got a few. You don't want to take it with oral potassium, an ACE inhibitor, or a potassium sparing diuretic. Anything, because all of them are going to increase the risk of hyperkalemia. Oh, the order reads give metoprolol 300 milligrams a day PO and 2 divided doses. The tablets are in 50 milligram strength. How many tablets will they get per dose? 3. Smart people. Somebody already did the math, right? Yeah. So 6 doses, or 6 tablets divided into 2 doses. Easy math. To prevent the development of tolerance to nitroglycerin, transdermal patch, a nurse instructs the patient to perform what action?
Check it off.
Right. Yep, perfect. You guys got that one. What teaching does the nurse include for a patient who takes liquid oral iron and their iron is specific to being liquid only? So what do you tell them? Take it, there you go, use a straw.
That's what you were looking for.
Yeah, stains the teeth, right? If they had said, what are we watching for? And you'd say stains the teeth. Which drug class is used to treat both hypertension and dysrhythmias? Calcium channel blockers are specifically indicated for both of those. A patient with an anemia caused by a deficiency in vitamin B12 due to lack of intrinsic factor has what kind of anemia?
Oh,
Yeah.
Pernicious.
Pernicious anemia.
I was like, the one with the patient board.
Yeah, pernicious. If you see it on a piece of paper, you'll recognize it. Pernicious anemia. During discharge teaching, what basic teaching should the nurse include for a person or prescribe transdermal quantities? So these are your instructions to the patient. Okay, that's always a good one. Take the old one off before we put a new one on. How often are they applied?
Rotate sides.
Rotate sides. Where should you place it on your body?
Hairless.
There you go.
Yes, yeah.
A less haired location. Let's see if there's anything else. clean, dry skin. They say don't cut it, don't touch the sticky surface. Typically, they're a week-long patch.
7 days.
Oh, yeah, it's a long patch. It's because clonidine by itself is a short-acting medication in pill form. And then rotating sites, and then if it falls off, you just go ahead and apply a new one. You don't wait till the end of the 7 days, you just go ahead and put a new one on.
I guess that is a question that's always in the anaphylaxis and SC about if the patch falls off, what do? Do you wait for the next dose? And it's like, no, apply right away, right? Yes.
Yeah.
Is that just with quantity or is that with
Like different patches.
any patches?
So
Yeah,
if it were a lidocaine patch,
Oh, I see.
you know, I would have to think about,
Because that's from like, with like the 12 on, 12 off type thing.
yeah.
If it fell off after like, say, 9 hours, would you really waste a whole patch for 3
Probably
hours?
not. I would read what the manufacturer had to say about their
Or
product.
do they usually have like that type of instruction in there?
Probably.
If you read the manufacturer's instruction, they have 9,000 instructions on that, in that tiny little print.
What if it's an anaphylaxis test and you can't
Yeah.
really read the instruction? Just place a new patch on the one.
Yeah. Fentanyl patch, same thing. You would place a new fentanyl patch. You wouldn't wait until.
Are those ones 12 on, 12 off?
Yeah, they're 3 days.
Okay.
Yeah. Let's see what else we got. What are some 3 signs or symptoms of cardiac glycoside toxicity? So what medicine are they referring to? Digoxin, right? We only talked about digoxin. So now they're asking, name some of the signs and symptoms of digoxin toxicity.
Visual disturbances.
Visual disturbances, right? That I see angels. No, I see halos or whatever. What else?
Yeah. Slow motion.
It's like nausea and vomiting are just a given for just about everything, I think. Oh, this is not working. All right, bradycardia, dysrhythmias, yeah. So because of its negative chronotropic effect, slowing down the heart rate, yeah, can lead to a dysrhythmia as well, which is always fun. A patient who is prescribed tamsulosin does not have a history of hypertension. The nurse knows this medication is also used for what condition?
Benign hyperplasia.
There you
Prostatic
go.
hyperplasia.
So what other meds were in this alpha class? Tamsulosin is not used for hypertension. It is only used for BPH, but what are some of the other ones that were used for hypertension? They end in osin,
It's the one that you just showed us.
doxazosin, terazosin, alfuzosin. I bet you could just make up a word and
I only remember because my patient that I had to write the care plan on him, and he was on that.
Yeah.
That's what I remember.
that's how it sticks in your head. We just call it little old man med.
Little.
The nurse will teach a patient who's receiving oral iron supplements to watch for expected adverse effects.
Carrie stools.
Tarry stools, right? What else? GI upset, yeah, constipation, potentially diarrhea. Those are, yeah, tummy pain. Okay, this is a 3-word answer. Warfarin prevents clots by preventing the clotting factors.
Oh, the 10.
What's the pathway?
Fibrin.
What's the pathway for warfarin? What we specifically talked about this dependent pathway, and it depends on probably a hard one. It's the vitamin K dependent pathway. Remember, there were multiple sites within warfarin that fell on this vitamin K dependent clotting pathway. That was a hard one, yeah. The nurse is reviewing the medical record of a patient before giving a new order for iron dextrose. What must be done before administering the dose?
Iron glucose.
All right, smarty pants. Something specific for iron dextrose. How is iron dextrose given? It's IV. So what did we say about IV iron? There was a one that you did something with and one that you didn't.
Oh, the initial dose.
Yeah, the
Oh,
test
25.
dose, right? And it's iron dextrose you have to do the test dose on. Yeah. So that's one that is known to come up, is asking about iron dextrose and the test dose.
And the sucrose is the one.
Iron sucrose, you don't need a test dose. What does the nurse recommend the patient to take to enhance absorption of oral iron forms? Vitamin C, right? Anything that contains vitamin C. During a follow-up appointment, a 58-year-old man is pleased to hear that his blood pressure is 118/64. I've been hoping to hear this good news. Now I can stop taking these pills, right?
No.
What's the nurse's answer? What's the best answer to say that's diplomatic and hopeful for the patient? No, we don't say nice try, but no.
Lifelong, you're
stuck
there.
We want to find a very optimistic way of saying this.
There's a long
The
line.
medications may be for life. However, you may reduce or you may increase the chance that you could come off of these meds if you exercise and lose weight. Yeah, if you're people who are really motivated to get off meds, that's the opening to talk to them about oftentimes the reason that they're on the meds. But yeah, obviously you and I know most likely this is for life, and most likely you're going to get more pills.
They said that the phone meetings, he was on his meds and was hypertensive, and he went to a plant-based diet and he could stop them.
It happens with lifestyle changes. It's just, that's the hardest thing to do, is to change our lifestyle. It's so much easier to take a pill. When monitoring a patient who has diabetes and is receiving a carbonic anhydrase inhibitor for edema, the nurse will monitor for which possible adverse effect. So what is a carbonic anhydrase inhibitor? What kind of drug is it? Goes by the initial CAI. It's a diuretic. Yeah, it's a diuretic, right? So just recognizing what it is, and now we know, okay, it's a diuretic in this class, and there's a precaution related to people with diabetes.
So someone like them like cover.
No, that's beta blockers. So it can elevate blood sugar and cause, what's glucosuria?
Sugar in the
Sugar in the pee, right? Sugar pee. When caring for a patient with angina, the nurse would question a prescription for a non-selective beta blocker in a patient with which pre-existing condition? Asthma. Yeah. Guys know that by now. Beta blockers and asthma. Before administering a eplerenone to a patient, what is the priority nursing action to prevent an adverse reaction? So what is eplerenone?
I know that it is potassium sparing.
There
So I
you go.
remember,
Good job.
because it inhibits aldosterone.
So exactly, if you just go back to what it's doing, we know what it is, we know what it does, we can generally figure out it's going to be an electrolyte abnormality. Want to make sure he's not hyperkalemic before we give him something. While monitoring a patient who's getting an infusion of a crystalloid, the nurse will monitor for which potential problem? Manifested as. And
Fluid overload.
so, yeah, fluid overload. this is general statement. You would want to know what those symptoms would present as, whether they have crackles in their lungs, whether they, when you're listening to heart sounds, if you can hear.
Short of breath.
You can, sometimes with people who are in fluid overload, if you're in the hospital and you have someone in there with heart failure and they're in fluid overload, listen to their heart sounds and really pay attention, like to things passing through the aortic and the pulmonic valves, because you can hear a lot. You can hear the fluid passing through when somebody's in fluid overload. It's not as loud as a waterfall, but to me, that's what I think of. It's a lot of fluid being forced through. So it's a good opportunity to listen. 3 food sources for folic acid. Spinach is one.
Or was that on there?
I think there was nuts and seeds.
The sunflower seeds.
Anything else? Dark leafy greens, yeah. Legumes. Yeah, a lot of things in there. So just recognizing probably the most common one that we talk about is like the spinach or the dark leafy greens. But just
So common
recognizing.
that it's there twice.
What is?
It's so
Spinach.
common that
Yeah,
it's there
spinach
twice.
and spinach, yeah.
Spinach.
But also knowing that it's available in all sorts of foods. Carvedilol reduces blood pressure by what 2 mechanisms of action?
It's a beta blocker.
So what kind of beta blocker is carvedilol?
Non-selective.
All right. So,
So it is selective.
Yeah, because it's in the same. hospital.
but it's carvedilol is partially selective. It's a cardioselective that's, yeah,
Doesn't fall in that class.
yeah. So what does carvedilol do to reduce blood pressure?
It's a vasodilator.
And?
Decreases inotropic. So it's a negative inotropic? Or is it a positive inotropic?
It's a decreased chronotropic. So it's going to slow the heart rate because inotrope was the force of the contraction. We're slowing the heart rate, and then it does have this alpha-1 receptor blockade. So it's not a beta specific beta blocker. It's beta-1 and then alpha-1. It doesn't have alpha-1 and alpha-2. Has beta-1 and alpha-1. So that's why you have 2 mechanisms of action. What's the antidote for an overdose of heparin? What is it? Protamine sulfate.
All right.
Good job. Extra points over there. Know your antidotes. Name the 2 non-dihydropyene calcium channel blockers that are used for dysrhythmias.
One starts with a D, and the other one starts with a B. VE.
Verapamil, yeah.
Yeah.
And Dylan, something.
Yeah.
Diltiazem.
Good
Diltiazem.
job. Way to pull it out.
I can't, it's.
Because all of the other calcium channel blockers are more of an antihypertensive. Well, they're also antidysrhythmic, where these ones are not used for hypertension, right? They're just used for dysrhythmias. How do you recognize the ones that are used for the purpose of hypertension? They're dihydropyridines, and then they end in ene, right? And what's their mechanism of action? They dilate. Yeah, good. Patients taking propanamide for a cardiac dysrhythmia. Oh, those dysrhythmias. The nurse will monitor the patient for what possible adverse effect? A different dysrhythmia. That is true. That is true.
You said it can cause.
All antidysrhythmics can cause a dysrhythmia. It's true. So specifically, we're looking for prolonged QT, and then it does have a propensity to cause diarrhea.
So do we need to know it as prolonged QT or torsades?
So they're different.
Okay.
Prolonged QT is what it leads to. The risk is that a prolonged QT can cause torsade.
Okay.
So not everyone who has a prolonged QT has this deadly thing, but it increases your risk. Pernicious anemia is caused by a lack of what gastric protein?
The factor.
The factors. The X factor. The intrinsic factor, good. Intrinsic factor. So don't get confused, because if they put B12 in a question, right? you can easily get CB12 and be like, oh, pernicious anemia. Ah, tricking you. Patient asked the nurse, what's the difference between dalteparin and heparin? Yeah, because patients ask that, right? What's your best response? What's that?
What? Nothing. I was being sarcastic.
Okay.
The both the same.
Dalteparin is long acting.
Yeah, there you
Yeah.
go. That's a key,
Oh.
right?
That's what you need to do.
Dalteparin is a low molecular weight heparin that's more predictable. It's longer acting, where we're not sending somebody home with heparin shots, right?
Why not?
Well, you know, if you want to kill them, I guess.
Is the dalteparin the enoxaparin?
Enoxaparin and dalteparin is a different drug. It's a cousin or a stepsister.
But it's like the same. So that's what
It's a low molecular weight heparin as well. Yeah. Calcium channel blocker is used to treat what type of angina? This book specifically gives, it's actually not. It's used to treat vasospastic or the Prinzmetal. Yeah. Yeah, that's the same term. Vasospastic means Prinzmetal. So, yeah, that was kind of a hard one. I had to actually double check that because I wasn't sure if I remembered correctly. Oh, we already went over this. What's the exact specific drug class of carvedilol?
Alpha 1, alpha beta.
Alpha
Beta
1, beta 1, right? Let's see if we can get dual action alpha 1, beta 1 receptor blocker. That's twice that's come up. So you might expect that carvedilol would be an important drug. The nurse needs to educate a patient taking amiodarone about what 3 potential serious adverse effects. What's amiodarone? Antidysrhythmic, right? So this is one of those drugs that you have to know about, and it's going to be on NCLEX, I can guarantee you, because amiodarone, they are expecting you, it's like the outlier drug you should know about.
No, it's like toward the end, like when you don't have any more options, you go to.
Well, this is a rhythm control medication. So a lot of the beta blocker, calcium channel blocker, diltiazem, verapamil, we're controlling rate. We start to get to the point where that's not working and we use things to control the rhythm. So amiodarone is one of them. What are the risks associated with amiodarone that you should be making sure that they know about, because oftentimes their prescriber doesn't tell them.
Torsades.
No liver, no torsade, no grapefruit, no. It actually grapefruit juice you can't take it with, but that's,
Is this the one that you have to worry about, like AFib, A-flutter?
it's used for AFib, A-flutter, especially really resistant AFib, A-flutter.
I know maybe
So
you
maybe
do.
So
concerned
these are
about
the people who end up with pulmonary toxicities, pulmonary fibrosis, and they need to have routine chest x-rays. It causes thyroid dysfunction directly from the medication. I've seen people become profoundly hypothyroid being on amiodarone. Yeah, it is hepatotoxic, has a black box warning. So those are the 3 big ones: lung toxicity, thyroid dysfunction, and hepatotoxic. But this is another one that you might see, corneal microdeposits. It's less severe, but they do need to get regular eye exams because of the risk of optic neuropathy, and that's not reversible. People like to keep their optic nerves generally. So yeah, know your potential serious adverse effects of amiodarone. Patient with elevated lipids has a new prescription for niacin. Which adverse effect may occur with this patient? With this medication, sorry. Now, what happens with niacin?
Pains, rash, and decreased blood pressure.
So here, anything, just about everything upsets the stomach, right? But yeah, know that niacin can cause upset, can cause flatulence, stomach pain, but of course the famous one is cutaneous flushing. The headache is also common. And so that's why it's helpful. If they're taking it for the cutaneous flushing, the aspirin, sometimes that'll help with the headache as well. What is a dietary precaution for patients taking warfarin? What do we tell them?
Take a
Don't
consistent
moderate.
amount.
Do we say don't eat dark leafy greens? Come on. Let's eat a consistent vitamin K daily, right? And dark leafy greens and all of the foods that happen to contain vitamin K. You never want to rule out a food class for somebody. The most common potential abnormal lab value for fibric acid derivatives is what? What are fibric acid derivatives used for? Not an anticoagulant.
Anti-lipid.
Anti-lipid, right? It's one of the forms of controlling cholesterol. Fibric acid derivative. Liver function tests, right? So knowing to watch your LFTs when you're taking phenylfibrate, gemfibrozil, any of those fibric acid. All right, when monitoring a patient who is receiving ivabradine, name 2 of all the possible adverse effects. Nausea, vomiting, elevated LFTs. Yeah, just something really nebulous. There's a lot. Bradycardia, AFib, and high blood pressure.
What is that? I don't even remember what that is for. I should look it up. Yeah, I should.
Helps you to learn them. So yeah, it's an antidysrhythmic, ivabradine. I'm not going to really worry about it. I just put that in case you wanted to know the exact class of it. Most of the antidysrhythmics work on sodium channels one way or another, slows the heart rate. And so obviously bradycardia is a potential adverse effect. However, high blood pressure is counterintuitive. As you think you were slowing blood pressure or slowing the heart rate, that you would have lower blood pressure. This is specific to this drug. What drug therapy stimulates the production of red blood cells? Good. The lipid-lowering drug, this lipid-lowering drug should generally be avoided in combination with statins. And what are statins? What do we use statins for? Simvastatin, atorvastatin, rosuvastatin. Lower cholesterol, right? So we're saying what other cholesterol-lowering drugs should be avoided with statins? There's a precaution in the book.
Well, this is the one that increases your chances of rhabdomyolysis.
Yeah, fibric acid derivatives. So we don't take like a gemfibrozil with a statin. Yeah, it increases your risk. So what were the labs that we were watching? The LFTs, right? And so what are the labs we watch with statins? LFTs, because it's hard on the liver. So we don't want 2 drugs necessarily. I mean, sometimes we might do it, but just learn it as we avoid it because of the increased risk of rhabdo. What is the most concerning potential adverse effect of antihypertensive medications in the older adult?
Hypertension.
Yeah, right. Hypertension and falls. Yeah, that's what we worry about. Happens all the time. Heparin does or does not break down a clot?
No.
Good.
Right.
Good. Which method of administration of anything has the longest duration of action?
Yeah. So does it only release so much medicine?
Yeah. It's a real art form to get medicine in a transdermal patch to penetrate through all of the barriers of the skin and all of the layers. You know, remember looking in your book at the cross section of skin. It's a trick to get medicine to pass through. So it's always going to be fairly slow onset and then slow duration of action. So they last the longest.
And then the longer people like them.
Yeah. What's that?
Half-life.
They have a longer half-life.
They have a longer half-life because it takes longer for it to absorb. that's
So
why it takes a
Half-life
while.
does depend on the route of administration, right? So the same thing, like IV morphine has a shorter half-life than an oral morphine. Name 3 teaching points for a patient who will be newly self-administering enoxaparin. So what are you teaching your patient and their discharge teaching? They're going home on an enoxaparin.
Give her own.
Rotate sites.
Wash your hand, rotate the side.
Yeah, what are the keys for, so what is enoxaparin first?
So
Low molecular weight heparin, it's an anticoagulant. So what are the precautions and how is it given? Is it PO, is it IV? Injection, okay, so those are the first things you figure out. What am I giving? I'm giving an anticoagulant. How is it administered? It's an injection. All right, so what are those things that I have to remember about that pre-filled injection?
Oh, don't, is this one of the air bubble?
Yeah, don't get rid of the air bubble. What else?
Don't massage it.
Don't massage it. Where don't you inject it?
You do it
2
with
inches.
some-
Where is
inches.
Right, 2 inches away from everything.
Everything.
Umbilicus, surgical incisions, brain, scar tissue.
I think give it in.
Oh,
Yes,
sorry.
yes, I've taken this so many
cute.
times. I know.
Subcutaneously, right? Yeah, and so looking at the patient, that's when you're giving them very specific teaching, depending on whether they're a frail little old lady or it's, you know, a larger person with extra tissue to spare. Rotate injection sites, don't aspirate. Yeah, got it. Here, I already told you this. What's the significance of patients seeing their potassium pills in their stool?
It's just the outside.
Is it right? Yep, it's a waxy matrix. In assessing a patient before administering a cardiac glycoside, the nurse knows that which low lab value can increase the toxicity of the drug.
Potassium.
If you have to guess. 9 times out of 10, it's going to be potassium. The nurse notes a patient's INR is 2.5. What's the meaning of this reported value?
That it's 2.5 times the normal bleeding rate.
Okay, and as far as therapeutic or non-therapeutic? Okay, so what is typically the larger therapeutic range for the INR? Do you remember? 2 to 3.5. So if they give you a 2.5, you can know it's most likely going to be therapeutic. So some are 2.0 to 3.0 and some are 2.5 to 3.5, but we just kind of, for teaching purposes, give the larger range. Before administering isozarbide mononitrate sustained release tablet to a patient, what is the priority nursing intervention? So what is isozarbide mononitrate?
Just remember that it's isozarbide mononitrate and the other one is
Neatness of the
nitrate.
It's a vasodilator, right? So used for 2 things.
Decrease blood pressure.
Hypertension and
Perfect.
Oh.
Oh,
in
in
China.
China.
There
Oh,
you
in
go.
China.
So what is the priority nursing intervention before you give it?
Sit down.
It's gonna be get a blood pressure reading.
My brain went to like what they need to do
Yeah.
before
For
they take it.
Gotcha.
Yeah.
Well, it's not nitro, so this is not gonna be like a sudden onset. So I wouldn't tell somebody to sit
Okay.
down and take your isosorbide. This is more like, make sure they're not hypotensive, so that we don't cause a syncopal episode and they break their hip while they're on the floor with you, and then you have to write an incident report. It's a big deal.
Call them.
Yeah, it's a nightmare. You have to deal with their daughter, who's like pissed off, and she's a lawyer. All right, the med order for a patient who's getting nutrition via feeding tube reads give digoxin 0.125 milligrams per feeding tube once every morning. The medication is available in liquid form, 50 mics per mil How many mil will the nurse give for each dose? Aha. Ooh. So what do you notice here? We've got milligrams and micrograms. So how many micrograms is 0.125 milligrams?
Multiply on one side.
Yeah, so it's 125 micrograms.
2.5.
So yeah. Woo! So that was just the trick there, making sure that you know how to convert milligrams to micrograms. Know your conversion factors, know your ounces, know your, remember, 5 easy math questions. The nurse will monitor for signs and symptoms of hyperkalemia if the patient is taking what type of diuretic? And there's more than one.
Sure. Which contain potassium.
Sorry, it was supposed to say hypokalemia.
Well, hyper would be.
Hyper, you were right.
Okay.
It would be potassium sparing diuretic. So sorry, I'll fix that, or you'll just make a note to yourself. So hypokalemia. I'm smoking crack.
Yeah, you're not bringing anything to us.
I don't know.
We're waiting.
This is pharmacology.
Pharmacology should be giving.
You started your
pills.
own math lab, like the guy from that.
So loop and thiazide, right? Both have the potential to cause hypokalemia. Loop is much more likely than a thiazide, but we still watch. What are potential adverse effects of quinidine? Ooh, that was in there with
Nausea, vomiting.
that was in there with like IV lidocaine. Let's go to it. All right.
Oh, you got it.
You're right.
Nausea, vomiting. I just say that every time. The key on this one is that they are looking for is this in the hearing changes. It's anywhere from tinnitus. What's tinnitus? Ringing hair, to high frequency hearing loss to profound hearing loss, and then visual changes as well. But the hearing one is the one that they're kind of going for as a kind of unusual potential side effect. What's the therapeutic range for digoxin?
2 to 3.5.
Yeah.
You said with such conviction that
I mean, it was good. Oh, she was confident. You're gonna be wrong. Be confident about it. Own your mistakes. Yeah, this is what we go for. If you look it up online, there's lots of variation. Every lab will be different, but for testing purposes, that's what we're looking for. Oh, it's really good though. Clopidogrel is what kind of drug?
It's
I have
Antiplatelet. Clopidogrel is Plavix. So it falls in the class with aspirin. Keeps the platelets from sticking together. The nurse is caring for a patient admitted with a GI bleed who's anticoagulated with warfarin. What are we going to be giving him? Vitamin K, right? We're going to be giving him either oral or IV, depending on how bad the bleed is and what his H&H looks like. And maybe some blood replacement products. Patients about to get iron destran injected. Which technique is appropriate when the nurse is administering this medicine? Yeah. Why?
It's super caustic.
It stains is the main thing. Yeah, stays where it goes.
Can it cause irritation?
Oh yeah.
If it comes?
I mean, most people do fine, but this is book learning, and then we, of course, giving it with normal saline IV. Patient's about to get a dose of a non-protein plasma expander, dextran. The nurse knows that this product is indicated for what type and rate of blood loss. Wow, that's a hard one. So we have to think about, okay, so what is dextran?
dextrose.
So is it a crystalloid or colloid? All right. So we're giving something to expand the plasma. Let's see, what was I going for? Oh, a slow loss. Okay. So if they have a slow loss and we're just replacing, trying to keep their, so if you're bleeding, you're losing your plasma proteins, right? It's lost, just like you've lost your heme, you've lost your clotting factors, you've lost a lot of things. So if it's a real slow one, we can just give a colloid volume expander while we're looking for the etiology. That was a hard one. Nurse knows that the overall purpose of taking a beta blocker in heart failure is what? What is the overall overarching goal or overarching mechanism function of a beta blocker?
To heart rate increase,
Yeah,
blood pressure.
it's
decrease,
cardioprotective. Why?
to prevent heart attack.
What? Why do we give it after a heart attack?
That's right. It blocks the.
See, like all the.
Catecholamines, right? So it prevents catecholamine, or doesn't prevent it, it reduces catecholamine I'm supposed to say mediated actions on the heart. And so secondary to that are what it actually does. Delay heart rate, delay AV node conduction, reduce contractility. But it's more about, this is the mechanism, we're interrupting catecholamines. Enoxaparin sodium is an anticoagulant used to prevent and treat deep vein thrombosis and pulmonary embolism. This medication is in which specific drug class? No, we already said it's an anticoagulant.
Oh,
Yes.
It has a specific class, low molecular weight heparin, right? So dalteparin and enoxaparin are specifically formulated. You don't need to know the chemical structure to know that it's low molecular weight, but you'll always see it abbreviated LMWH, and you'll know that this is a low molecular heparin. It's going to be injected. It's going to last a while. What's an expected mechanism of action related to administration? What's the expected mechanism of action for digoxin?
To decrease the heart rate and heart.
Let's see what we got. Video. So slowing the AV node conduction, which decreases the heart rate, which increases the cardiac output, because a slower heart rate allows time for the ventricles to fill, and then it can interrupt some of the dysrhythmias with this slowing of the AV node conduction. So, patient who's severely anemic also has acute heart failure with severe edema due to fluid overload. The prescriber wants to raise their H&H. The nurse anticipates that the patient will receive which blood product? Why would we just give packed red blood cells?
because you don't want to increase the amount of fluid.
Right.
It's already
Right,
overloaded.
they're already in volume overload, so we don't want to give whole blood. Yeah, packed red blood cells, perfect. What do we monitor for warfarin therapy? UTINR, right? Here's a fella, 46-year-old guy, started an antihypertensive drug 3 months earlier, and he tells you while you were checking his blood pressure that he has had some problem with sexual intercourse. What's the most appropriate response?
Yes.
Is that going to make him feel better?
No.
No.
So obviously we're looking for, I'm trying to emphasize, like, you give the same information in a way that you are turning it into something they can be hopeful for. So just like, am I going to be on this medication for the rest of, can I stop it? You want to give them hope. Well, if you do this, there's a chance. So what you want to say is, yes, you can say, oh, that is a known side effect. Tell your provider so they can work with you to change the dose or the drug.
Can't they also add another drug to help with that as well?
That is bad medical practice.
Like sildenafil,
Something
something like that. No,
It's bad,
Viagra.
bad medical practice to add a drug for the side effect of a drug.
Yeah.
The best practice is to change the drug.
Well, aren't you also not supposed to because they're both
Yeah,
vasodilators?
Well, so this guy, this is more specific for like a beta blocker. And I probably,
So they would probably lower the dose.
they could lower the dose depending on a lot of factors. So if they are acutely after an MI, then they may not. They may say, well, they may have a discussion with you about risks and benefits. Like, we're doing this because we know we can delay the progression of heart failure. You know, can you wait till this point until we can lower the drug? Or if it was just a choice of drug because that was the next one you added on, then you can talk about lowering the dose and monitoring and then maybe adding something else like an ACE inhibitor or a thiazide diuretic. So generally we want to give people hope for the things that are important to them. They tell you it's important, then you make it important. They tell you that their dog's important, you learn their dog's name. In the nurse. The nurse will monitor for myopathy when the patient is taking which class of anti-lipemics. That's right. So that's a big one you need to know. Statin-induced myopathy. What is the antidote used to reverse the anticoagulation effects for factor 10A inhibitors like rivaroxaban and apixaban? You can just use the brand name. Has an X in it, remember? We noted that it had 2 X's and it had 2 A's. Starts with an A and ends with an A.
I haven't gotten there yet.
And Dexa. I haven't gotten there yet.
No, I haven't
Right?
studied it.
So it's a nice one to remember when you see 10A, then you can see the A's and the X's, right? It's helpful to remember. Those clever drug manufacturers. Nurse is preparing to transfuse a patient with a unit of packed red blood cells. Which IV solution is correct to use? Normal saline, yeah. When in doubt, normal saline is your go-to. Antifibrinolytics prevent the lysis of, right? Right. It's the one that's the double negative. It's like the preventing the breakdown of fibrin. Fibrates are contraindicated if there's what active disease state. Now that you know which labs to monitor, it should give you a clue. Yeah. So liver disease, remember they have elevated LFTs. So, and this is gallbladder disease and then renal disease. And generally, we're not giving fibrates to patients in severe renal disease because they're too far gone. So I would pay attention to the liver and gallbladder disease. You can remember that when you remember that most of the anti-lipemic therapies are you're checking liver function. Patients in an urgent care center is getting treatment for mild hyponatremia. After doing several hours of gardening work in the heat of the day, the nurse will expect that which fluid would be used to treat his condition. It's just mild. So he's got he's out in the sun doing some gardening.
Is that normal saline?
Yeah, we would just give normal saline. It's hypertonic solutions are high risk, and we really don't give them in an inpatient setting. So basically, we're just gonna, even though he's mildly hyponatremic, and we're only increasing his fluid volume, the greater it will correct itself. The greater risk is that he's volume depleted. So we just give him a little NS, send him on his way.
With a huge bill.
With a big, yeah, that NS was like $1,200, and then there's an IV insertion fee, and there's a fee for the cotton swab, and don't look at those bills. What are the 3 key points of storing nitroglycerin sublingual tablets?
Keeping it in a bottle or keep it on direct sunlight and throw it away after
Yes.
There's
Don't
quite a
mix
few.
them.
Keep it in the original bottle, throw it away after 3 months, store it away from the heat. Once you've opened it, they say to take the cotton out and then don't mix your bottles with nitroglycerin.
Why the cotton? I was gonna ask you this last time.
Yeah, cotton. They told you.
So the cotton is in there when it's airtight, just to prevent the medicine from sliding around and crushing. But I don't know whether it's has to do with once you've exposed it to air, if there's a faster chemical breakdown of nitroglycerin. Pull from the back of my brain.
All medication they mostly put in cotton.
Yeah, for packing, most of them do, but in this specific one, I believe it enhances the degradation of the product.
Like the cotton.
Uh-huh. Yeah, and so they say take it out. Keep your nitro fresh longer. The anti-lipemic drug ezetimibe works by what mechanism? There were 2 that worked in this mechanism. Similar mechanism, mechani. Inhibiting cholesterol absorption in the small intestine. Do you remember what other drug inhibited cholesterol absorption in the small intestine? By binding bile acid sequestration. Sound familiar? 79-year-old woman has been admitted to the ED after having severe headaches and feeling faint. Her blood pressure is only 286/190. Ooh. The sodium nitroprusside infusion is started, and the nurse is monitoring the patient closely. After 8 minutes, the nurse notes that her blood pressure suddenly drops to 100/60. What's the nurse's priority action? Stop your infusion. So it's a super fast half-life of this med. And you're going to be monitoring and getting a hold of whoever is prescribing this in the meantime. But yeah, excessive hypotension is the main symptom of toxicity or overdose. Patient is in the ICU getting milrinone for severe heart failure. Remember milrinone? How do you give the furosemide? And it was on our question, so I was give it in a different line. Patients taking an aminoglycoside for pneumonia, it's an antibiotic, and also will take furosemide. The nurse will monitor for what potential interaction from these 2 drugs. It was a simple question. So aminoglycosides, when we get to antibiotics, are famous for ototoxicity. So the combination of it with furosemide puts it at even higher risk. Everybody know what ototoxicity is?
Yeah.
All right. African Americans often respond better to which combination of 2 antihypertensive medications?
Calcium blockers.
Diuretics.
Diuretics.
Diuretics and calcium channel blockers, right? How long does the nurse advise the patient that statin therapy will take until there's a change in his lipid values? They generally tell them 6 to 8 weeks minimum. I generally don't check them before 10 weeks. So what do we tell a patient they can take for headaches when they're on warfarin? Or what do they avoid? Yeah, they avoid the NSAIDs, take Tylenol. Phosphodiesterase inhibitors have added advantage in treating heart failures. These drugs cause a positive inotropic effect, and what other effect? Right. All right. Well, I'm going to let you go, and this will post at 5:30. Just remember to change the question that said hyperkalemia to hypokalemia, so that you don't get a question wrong. All right. Good luck. Study hard. Keep down. Hundreds all around. I can feel it. Hundreds.
Oh, yeah. Okay.
Pushing 100 your way. Over there.
Oh, I would love that. I never got to my husband. I know. Really? Yeah, I like this one. This is a little crazy, but like, it's like my own.
It's terrible.